Okay, now we're going to take a look at the endocrine system. And the endocrine system, as you can recall, is responsible for a number of things, um, mainly for energy and metabolism, growth, development, helps regulate the vital functions throughout our body, helps us to respond to stress and injury that's happening, whether that's internally because we've come into contact with a viral or bacterial invader, or whether that's externally from emotional stress to physical stress. It also has to do with reproduction. We're going to touch on it in block 2. You're going to cover it more thoroughly in block 3. And then, of course, as we have already covered fluid and electrolytes and acid-base imbalances, the endocrine system is definitely involved with that process. So specifically, we are going to take a look at the thyroid, parathyroid, and the pancreas glands. Pancreas gland. So first, let's take a look at the pancreas, and specifically, we're going to talk about diabetes mellitus, type 1 and type 2. We know generally that the pancreas is located in the posterior, it's located behind the liver in the left upper quadrant in the body. We know that it contains the islets of Langerhans glands in the intestines. And we know that these glands are responsible for the alpha and beta cells. We know that the pancreas influences how fat, protein, and carbohydrates are metabolized within the body. So breaking this down further, looking at the alpha cells, we know that their job is to secrete glucagon, which will increase blood glucose concentration. Moving on to the beta cells, their job is to secrete insulin, which helps lower blood glucose levels. And when something goes awry in the body, and we're going to talk later about what our theory is behind when the pancreas goes awry with the alpha and beta cells, then we have diseases like diabetes. Type 1 diabetes is the failure of the beta cells to secrete enough insulin. And type 2 diabetes is the failure of the alpha cells to, for those insulin receptors to respond appropriately to the insulin that already exists in the body. So let's move on. We know that diabetes is a group of diseases that are classified based on hyperglycemia, and it causes, this is caused by defects in our insulin secretion, the insulin action within the body itself, or a combination of both usually. We know that there are over 25.8 million people in the United States that currently has diabetes, and it's staggering to think, but 1/3 of these cases are undiagnosed. So we have about 1/3 of the population going around that have diabetes that are unaware that they do. Again, the prevalence in the United States is increasing. And we know that the minority populations and older adults are impacted at a much higher rate. And that is due to the fact that genetically, minority adults are at a higher predisposition to getting diabetes based genetically on their makeup of their genetic makeup. And we know that older adults, as we age, we know that those receptors are no longer as sharp as they used to be when they were younger. So insulin, what's the function of insulin in our body? Well, we know insulin transports and metabolizes glucose for energy. So insulin is the key that glucose needs in order to utilize what's in the body for energy. Insulin also stimulates storage of glucose in the liver, as well as in the muscle as glycogen. Insulin also signals the liver to stop releasing glucose. So if there's some type of malfunction within the body and we don't have that signal for the liver to stop releasing glucose, then we have an overproduction of glucose happening in the body. That's one instance that can definitely happen. Insulin also enhances storage of dietary fat in adipose tissue. It accelerates transport of amino acids into cells. And finally, insulin inhibits the breakdown of stored glucose, protein, and fat when needed. First, we're going to take a look at type 1 diabetes. This is when insulin-producing beta cells in the pancreas are destroyed, and this happens or occurs by a combination of things. This includes autoimmune or immunologic reasons, genetic reasons, and or environmental reasons, and it could be a combination of all three. Although we don't know the exact cause, we know that genetically that is definitely a factor. We know that the environment is most likely a factor, and we know that immunologically it is a factor as well. As a result, we have a decreased insulin production. We also have this glucose production by the liver that is just not regulated. It's just releasing tons and tons of glucose into the body by the liver. And then we know we have a fasting hyperglycemic as a result. Type 1 diabetes affects approximately 5% of the adults with diabetes, children and adults with diabetes. We know that in the past that we used to call type 1 diabetes juvenile diabetes because generally speaking, it impacts younger individuals. We start to see the onset be, 10 to 15 is the average onset for type 1 diabetes. We don't know the exact cause, but we know that our body's own immune system destroys pancreatic beta cells. And as a result, the body stops making insulin. We have to have insulin to sustain life. So this is, this is not something we can live without. Our pancreatic beta cells are destroyed, and therefore our body's not able to produce or create insulin, and therefore we have to put artificial insulin into patients' lives to help them sustain life and to live a quality healthy life as well. Again, exact cause unknown, but we know there are an autoimmune undermining effect genetically, and then environmental factors that also influence why these beta cells get destroyed. When we're looking at diabetes mellitus type 1, polyuria, we see an increase in the amount of urination. Polydipsia, there's an increase in the thirst mechanism within the body. And then polyphagia, there's an increase in hunger within the body. Although we have this increase in hunger, the number one cause that brings patients into the physician's office when their kids or teenagers aren't feeling well, or if an adult comes down with type 1 diabetes, it's because they're losing weight at an astronomical rate and they're not even trying to lose weight. These are individuals that aren't on a diet. They have no reason to lose weight, but their body is wasting away. And that's because they don't have that insulin in the body that helps convert the glucose to energy, right? So think about that. That's going to cause them to be extremely fatigued and exhausted and unable to do simple things like, going to school, and definitely not participating in sports in school and enjoying, the luxuries of life, like going out and having a dinner and just being able to enjoy that. They're so exhausted, it takes away their energy to do the minutest of things. We are going to see an increase in the frequency of infections. So their immune system is definitely not functioning at 100%. So they're going to have an increase of infections. This is something when someone comes down with type 1 diabetes, it's not something gradual, as we'll see and we'll talk about with type 2 diabetes. It happens quickly. So patients their beta cells will be working fine one day, and then the next they won't. And again, the underlying cause being unknown, but there's probably a combination of environmentally, the chemicals and the stress in our life, and all of this, our genetic makeup is all, part of why those cells, those beta cells get destroyed. So the beta cells get destroyed, and you see this overnight inability to produce insulin, and therefore the patients then will present to the physician's office with all these signs and symptoms. There will be some tests done. We will talk about them later. And then once the patient is diagnosed with diabetes, then type 1 will be insulin dependent the remainder of their life, unless their pancreatic cells kick in and start producing insulin. I have to be honest, that is very rare when a patient has pancreatic beta cells that have been destroyed, that, produce insulin, they've been destroyed, that all of a sudden start working later in life. But it does happen, and it's an anomaly, and it is being researched now as to why is that and how can we reproduce that. Obviously, that's something really would be incredible to be able to help our type 1 diabetes reproduce those beta cells that can produce insulin. Therefore, those individuals on insulin dependent injections can come off that, right, and live a healthy life with their own body producing that insulin. So we are looking into those rare cases right now. Again, early onset is the majority of cases seen before the age of 15. Now, looking at type 2 diabetes, the problem isn't that they're not producing insulin. The problem is the insulin receptors are not as sharp, and as they're impaired. So they don't, they resist the uptake, and the insulin receptors resist doing their job. So they're there, but the insulin receptors are there, but they're just not working at 100%. And there is some impaired insulin secretion as well. That's a second part of the type 2 diabetic regimen. But please be aware, the majority of type 2 diabetes patients have the insulin receptors in their body from the beta cells. They're just not working at 100%. This is most of the cases you're going to see as nurses is going to be patients who have type 2 diabetes. And the average onset for type 2 diabetes is around the age of 30. And we did note in class that we had a 6-year-old and a 9-year-old like 2 weeks ago that have type 2 diabetes onset. And they were obese children who has obviously impaired ability to utilize those insulin receptors appropriately. So again, type 1 is extremely fast acting, happens overnight, and then within a week or two they're in the doctor's office, because you cannot sustain life with type 1 diabetes. You have to have insulin in order to convert glucose to energy. With type 2, it's very slow progressing. You will be very asymptomatic in the beginning, not even know that there's problems until that excess glucose has injured those small vessels behind the eyes, or patients start having erectile dysfunction or decreased or absent libido, and you start to see signs and symptoms of the destruction that's occurring in the body. So again, it's a slow progression of glucose intolerance that may go undetected for years. And the longer it goes undetected, the worse the damage will occur. Type 2 diabetes occurs in approximately 95% of all cases of diabetes mellitus. And in the beginning, it is insulin resistance, meaning that the cells aren't utilizing the insulin properly. And we associate type 2 diabetes with older age, obesity, families that have a genetic predisposition for diabetes, patients who have prior gestational diabetes, physical inactivity is a big one, and then of course there's an underlying race or ethnic link there. But out of all of these factors, the most important factors are the family history and, of course, being obese. Again, early stages can be totally asymptomatic, meaning there are no signs and symptoms. The patient's unaware. Later on, though, we start to see signs and symptoms because of the damage. So we'll start to see visual problems, infections that won't heal, fatigue, exhaustion, that all the time. So again, the clinical manifestations of what's going on in the body occur so gradually that before we know it, we're having some pretty big complications. The patient is. So the main goal of medical management of diabetes is to normalize insulin activity within the body and blood glucose levels as well. And we want to do that to reduce the development of complications, right? We're looking to reduce permanent problems with that patient's body. The ADA now recommends any patients who has diabetes mellitus to have an HbA1c less than 7%. Remember that A1C, glycosylated hemoglobin, or the HbA1c, it's all the same thing, measures how well a patient's glucose level was maintained within the last 90 days. We want it for diabetic patients to be below 7%, and for a healthy individual, it should be around 5%. Diabetes management has 5 components, right? It's not just dealing with, if it's type 1 that we need to put insulin in the body, or type 2 that we need to get those receptors to be more susceptible. There's a whole regimen that we have with diabetes management. First and foremost, we need to get these patients up and working out. They need to come up with some exercise plan. And of course, as the patient gets more energy, that exercise plan will expand, right? And they'll be able to do more once we level out and lower their fatigue. So one, there's an exercise plan in place. We also are going to give them nutritional plan where we're going to recommend certain foods that are healthy and that are that will provide instant energy, and also show them where the hidden sugars are at and what to avoid, so that white bread, milk, whole milk, those kinds of things turn to sugar in the body. So we need to educate our patients on those hidden sugars. Patients are going to need to monitor their blood glucose extremely closely and adjust, their insulin levels, or adjust their food options based on how well or how poor their blood sugar is managed. We are definitely going to have a pharmacological therapy involved based on the type of diabetes they have. We already discussed type 1 will be on some type of insulin replacement therapy, and type 2 will have some help with, for example, metformin to help with those receptors. And we may even add glyburide down the road depending upon how well the patient's doing. And then, of course, there's lots of education, right? Education on how to take their insulin injections, where they give the injections, what the injections are for, how many units of insulin that they need to inject, the type of insulin they need to inject, when they inject that insulin, when do they need to be on the lookout for hypoglycemic signs and symptoms, foods that they should eat and lean toward, and foods that they need to avoid, and so on and so on. So there's lots of education going on with our patients. So looking at our dietary goals for these patients, we want to manage total caloric intake to maintain a reasonable body weight. So for our type 2 diabetic patients, we know that many of them, not all, but many of them are obese. So part of that is we've got to come up with a plan that we can assist them in helping shedding some of those pounds, right? They need to lose some of that weight. And while they do so, we're going to want to be controlling their blood glucose levels. The kind of diet that these patients are going to go on to is going to be a very controlled, physician-controlled diet, because it's not like they can go on the Atkins diet, or they can go on the keto diet, or they can go in the Mediterranean diet without having a physician look over that. I'm not saying they can't go on any one of those diets, but they're whatever diet plan they're going to work out, it's going to be in conjunction with their physician watching over them, right? Because we want to watch the pitfalls of that, and we want them to understand how fat works in the body when there's a problem with insulin receptors, and there's a problem with the alpha cells and beta cells, right? Because it can, as we discussed in class, it can inhibit absorption, and we want to look at all kinds of factors that can cause a patient to become hypoglycemic as well as hyperglycemic. They need to stay in that happy homeostatic blood sugar range. The diet is also going to be part of looking at the lipids, right? And we want to normalize the amount of lipids in the body because we don't want to add additional medical problems in the body like high lipids, and now they need to be on some type of statin, right, to lower cholesterol. And also blood pressure. We don't want the patient's blood pressure to be elevated. And of course, we don't want them to end up getting heart disease in the long run because of the mismanagement of the totality of what's going on when you have diabetes. So looking at the meal planning, we want to consider food preferences. We also, when we're doing that, we're going to definitely look at their lifestyle. We're going to look at their ethnicity. That's definitely a big aspect. We don't want them to give up all of their foods that they enjoy that are ethnically, they've been raised on their entire life. We're just going to teach them that if it's foods that are high in fat or high in sugar, we're going to limit the amount of days per month that they're allowed to eat those types of foods, right? So it's not that they're going to get rid of them completely, but they're going to have to lessen the occurrence of those types of foods. We are also going to look at what's the patient's typical eating times, and that's usually a really big one. We notice patients will go hours and hours and hours without eating anything, and then they're eating really late at night, like an hour before bed, and then they're going straight to bed. And we know evidence-based has showed us that going to bed on a full stomach is the worst way for our body to try to metabolize food. We know that when we're sleeping, our body starts to shut down as far as all of our functions in our body. Shut down or slow down, like our heart slows down. Processing food doesn't happen effectively when our body's working much slower, right? So it's important that we educate patients who have diabetes that we want them to, instead of waiting all day not eating, we want them to start with a good breakfast, and we want them to have a couple snacks throughout the day so that they're eating something consistently every 2 to 3 hours, and they're keeping their blood glucose levels even and steady throughout the day, right? So they're going to come up with a diet plan with their physician, and they're going to review what their current diet history is, and then they're going to come up with a new diet plan. And if the patient needs to lose weight, then that will be part of it and how they do that. And if the patient needs to gain weight, so if it's a type 1 patient who comes in and because the number one thing that brings them into the doctor's office is that weight loss. Maybe they've gotten to a point that they've lost so much weight and muscle even that we need them to gain weight. So they're going to add calories. The physician's meal plan will be in the beginning that they're going to eat more calories than is needed, right? To increase that, their weight and get them in the weight range that they should be in. And then of course they're going to have a new diet plan once they get to the weight that they should be based on their age, height, and then we're going to come up with a maintenance diet plan at that point. Looking in general, though, at the meal planning for a diabetic, we want approximately 50 to 60% of their diet to be carbohydrates, more specifically complex carbohydrates, right? Remember, simple carbs turn to sugar in the body immediately. So we want it to be complex carbs. This would include whole grains. We want to emphasize whole grains because they're quality carbs that will also give the patient a feeling of being full as well. Fat, 30% of the caloric intake will be fat, but we're going to make sure that 20% of that fat, those fats, are good fats. And then we want to limit only 10% to those saturated fats, right? Which is literally less than 300 milligrams of cholesterol a day. And then looking at, we're going to push non-animal sources of protein. So whole grains, legumes, things that are going to increase the fiber in our diet. Fiber is definitely much better for our overall body health, and it's much more better for our colon too. So you can look at table 51-2 for an exchange list of food for diabetic patients. That will help you in educating your patients. So we're taking a look at the glycemic index. Now, the glycemic index is a system that ranks foods on a scale from 1 to 100, and it bases this scale on how that food has an effect on blood sugar levels in the body. So we know when we combine starchy foods with proteins and fat, this slows absorption, right? So that's important to know because that does impact the glycemic response that's happening in the body. We are going to encourage raw or whole foods because they have a lower glycemic response than cooked, chopped, or pureed foods, right? You know that you've heard before that cooking something takes out all of the vitamins and essential elements of that food. That's a true thing, right? Steaming is better than cooking, but it still causes a little bit of loss of the vitamins and essential parts of that food, whether it's broccoli or carrots or whatever. The whole fruits rather than juices are much better, right? We know that there's hidden sugars in juices, so if you eat whole fruits rather than juices, this will decrease the glycemic response because of fiber, which of course slows absorption. Adding foods with sugars may produce lower response if eaten with foods that are more slowly absorbed. So we need to keep that in the back of our mind, right? So again, adding food with sugars lowers our response, even if we're eating foods that are good for us. So that sugar literally gets in the way of how we absorb the good stuff that we're eating. So keep that in mind, especially if you're drinking juices that are high in sugar, but you're eating the great, fiber and whole grains. That sugar that we're drinking is going to disrupt our uptake of the good from what we're eating. And then other things that we need to be alert is alcohol. Alcohol has hidden sugars in it and affects the body very negatively when we're looking at diabetics. And got to be real careful with those nutritive and non-nutritive sweeteners. Talked about that. And then of course misleading food labels like fat-free. Well, it's fat-free because it's got 100% sugar, right? So just got to be real careful with those labels, and you got to start reading labels because there's hidden sugar, salt, fat in a lot of the foods we eat. We talked about salt earlier this block when we were discussing foods that patients microwave because it's a preservative, right? But it's really high in salt. So you just got to watch and start reading those food labels and teach your patient to do that. So looking at side effects of having diabetes, patients can have either hyperglycemia or hypoglycemia. We know that hypoglycemia is much more dangerous than hyperglycemia. So let's first take a look at hyperglycemia. Hyperglycemia will present itself with more frequent urination or polyuria, more thirsty, being extremely thirsty more frequently. That's polydipsia. They're going to have blurred vision, weight loss, increased hunger, polyphagia, unexplained fatigue, and that's like from the time they wake up. Even if they got a good night's rest, they still have that fatigue. And then, of course, the wounds that don't heal. So when you get a skin infection or a wound, it's not healing, right? Because there's too much sugar in the body that's preventing the body's ability to heal those wounds. How do we treat hyperglycemia? Well, we are going to give a dose of insulin that's going to cover that hyperglycemic event. And if the patient is extremely hyperglycemic, then they could end up in the hospital. For example, if they have a blood sugar of 800, they're definitely going to end up in the ED. And if we can't get their blood sugar level managed, then we're going to admit them for a hospital stay until we can get their blood sugar levels back under control. Now we're going to look at hypoglycemia, which of course again is much worse than hyperglycemia in the long run. They both can kill you. Hypo and hyperglycemia can kill you, but hypoglycemia can kill you much quicker. Now, hypoglycemia is when we're looking at the blood glucose level falling below 50 to 60. I would say anything below 60 would be considered hypoglycemic. And of course, the lower you get below 60, the worse off the patient is, right? Because we need those sugars in our blood to provide energy to our brain. And if our brain is without those sugars for any extended period of time, then we're going to have tissue death going on. So it's very, very important that we get these low blood glucose levels raised. So we can get hypoglycemic from a number of ways. We can cause our patients to become hypoglycemic, or they can cause themselves to become hypoglycemic if they've administered too much insulin. And there's so many scenarios. For example, the patient who has type 1 thinks they're going to have, a cheeseburger for their cheat meal for the week. So they type in the amount of insulin they're going to need into their insulin pump. But then when they start eating the cheeseburger in the restaurant, they don't like how the cook made it, right? So now all of a sudden they have excess insulin in their body and not enough calories coming behind it to ensure that they don't become hypoglycemic. We can also cause that in the hospital if we administer their insulin injections for their breakfast before the trays are actually sitting in front of them. Don't anticipate that the food trays in the hospital or the facility that you work at will be on time. They run early sometimes, and sometimes they run late. So the rule of thumb is you give the insulin in their fast-acting or rapid-acting insulin injection to cover the food that they're eating once the tray is sitting in front of them, right? And then also we can end up giving them too much oral hypoglycemic agents. This can definitely lead to hypoglycemia. Also, the patient could have gotten up and been in a really great mood and decided they were going to work out to try to shed some of the weight, and they ended up having really excessive physical activity, which we know would send a patient into hypoglycemia. Or they're just not eating enough food, again, based on the amount of insulin that they're taking in. Hypoglycemic patients are going to present in very similar fashion. They're going to be sweaty. They're going to have heart palpitations, tachycardic. They're going to be nervous, tremors, hungry, inability to concentrate, headaches, confusion, memory lapses, drowsiness, slurred speech. They're going to be disoriented. They could, if it goes on for long periods of time, they could have seizures, loss of consciousness, death. They're going to be nauseous. And remember that that cold and clammy, needs some candy, that's the hypoglycemic patient. It's not a hot sweat, it's a cold sweat where they're literally head to toe covered in sweat. And so that's the kind of sweating that occurs with hypoglycemia. Because remember what's happening in the body, right? Is that they have low blood glucose levels. That's why that's the type of sweating that's occurring in the body. Next, we're going to look at a phenomenon called morning hyperglycemia. And this can occur due to one of three things, right? So we either have a progressive rise in blood glucose from bedtime to morning is one of the reasons that you wake up, that patients will wake up who have diabetes in the morning and have really high blood sugar. How we fix that, if they're that type of patient, is we will increase their evening dose of intermediate or long-acting insulin, or the physician will add a dose of insulin before the evening meal if one is not already in play. So if they already have a dose in play, they're going to increase that dose. But if a dose is not as part of their orders, we're going to add a dose of insulin before their evening meal. This should increase that rise in glucose from the time they go to bed to when they wake up in the morning in that instance. The second type that we see with patients is where they'll have a relatively normal blood glucose from, the time they go to bed, 9, 10, until around 3 a.m. That's when all of a sudden they'll have this hyperglycemia start to, the blood sugar starts to rise. How we fix that is we just adjust the time of their intermediate acting insulin. And we do that from changing it from dinner time to when they actually go to bed. So it'll cover them for a longer period of time. And then finally, the third one, and one that you don't see as frequently, is called the Somogyi effect. And that's where you have normal or elevated blood glucose at bedtime, and then it drops around 3 a.m., so you're hypoglycemic. And then you have a subsequent increase caused by the production of your hormones. So the way we fix this is we'll decrease the evening dose or the pre-dinner bedtime dose of our intermediate active insulin, or we'll increase our bedtime snack, or there might be a combination of both, depending upon how the doctor would like to do that. So again, the Somogyi effect is when you have a normal or elevated blood glucose level at bedtime, and then it drops at 3 a.m. So you end up being hypoglycemic. You wake up, you're covered in sweat, you have all of the signs and symptoms that we mentioned before with the hypoglycemia, okay? And we fix that by decreasing the dose of intermediate dose that we're giving, and or increase a bedtime snack. Again, how do we treat hypoglycemia? Well, we give the patient 15 grams of a carbohydrate, simple carbs, right? So you can do that by giving them 6 ounces of juice, right? So orange juice, apple juice. You can give them milk as long as they're able to swallow. You can give them milk, juice. You can give them a piece of bread if they're able to swallow. And then what we want to do is wait 15 minutes after giving them 4 to 6 ounces of whatever our choice is or what we have on hand, and then retest their blood sugar. And if it's still below 70, we're going to do the same thing again. Give them 15 grams of sugar, whatever sort we have on hand. If they have those glucose tabs, that's 3 to 4 glucose tabs. And then we want to continue until we get the blood glucose levels above 70. Once the blood sugar is above 70, then we want to make sure we talk to the patient about having a protein snack, or if it's time for their meal, just going ahead and having them eat their full meal so that they get some quality protein and complex carbs in there so that the patient's blood sugar won't end up doing the same thing in a half an hour to an hour, right? So within a half an hour to an hour, they got to have a quality meal or a really good protein complex carb snack to sustain the blood glucose levels. Now, if the patient's unconscious and they're not able to swallow that juice or bread or milk, then we're going to give them 1 milligram sub-Q or IM of glucagon. So glucagon intramuscular, and now it's really thick. Remember, this is sugar. So we're going to usually use our thigh, the patient's thigh, or their hip in the back, high up. Or we can do it sub-Q as well. I prefer intramuscular just because it's less painful on the patient, and it will sustain a little bit longer because we know anything that goes into the muscle will have a longer acting effect. If we have IV access, then we can also do 25 to 50 mils of D50 via IV. That's if you call 911 for a patient who's hyperglycemic and unconscious, that's what we do when we come in as paramedics. We give D50 via IV. We slam it in there and get them, they come back pretty quickly with that. So again, hypoglycemic, because it's so important and can be deadly signs and symptoms. They're nauseous. They're going to have rapid, shallow respirations. Head to toe, they're going to be having cold sweats. They're going to be diaphoretic, weak, trembling, tachycardic. And when you test their blood sugar, they're typically going to be below 60, around 55, 50, 45, somewhere around there. Treat with 15 grams of fast-acting simple carbohydrates. So that's 3 to 4 glucose tabs, or 4 to 6 ounces of juice, or regular soda. Remember, educate. Diet soda is not going to do a darn thing. We need the sugar. Then we're going to follow up with a quality carb like pure peanut butter, cheese and crackers, or a meal, right? Now, we're going to keep checking their glucose, though, for a good hour to 2 hours after, or we're going to have the patient do that to make sure they sustain their 70 or above, right? If they dip below 70 again, then they're going to treat it just like we just said, right? 15 grams of fast-acting simple carbohydrates, right? And then they're going to be doing that until their blood sugar rises above 70, and then we're going to want to sustain that. So again, if I as a paramedic comes in, I'm going to use D50 via IV, and patients at home or home health nurses or hospice nurses will have access to glucagon, and they, with IM or sub-Q, and they can give it to the patient that way. Here's a great mnemonic to try to know the difference between, are they hyper or hypoglycemic? Hot and dry, sugar high. So when you see somebody who's hyperglycemic, they're not going to be covered in cold and clammy sweat, right? They're going to be dry. And then cold and clammy is the hypoglycemia, and they need some candy. So, what are the tests that we use for diabetics and help regulating, first diagnosing someone who has diabetes, and then managing and regulating moving forward? Well, if a physician suspects when a patient comes in that they have diabetes, right? The patient comes in, they're 55, 60, they're complaining that they must be getting older because they got blurred vision, but they have other things going on that worries the doctor, and they want to test to see exactly what's happening in the body. They want to rule out diabetes just because as we age, we know we're at a higher risk of getting type 2 diabetes, right? So the physician will order a GTT or a glucose tolerance test, and they want to see if the patient does in fact have an impaired ability for their body to handle excess glucose in the body. So they order the GTT test. The patient goes into whatever facility is doing the exams, and we do them all over the hospital in an outpatient setting. Patient comes in, they will change into a gown, and they will also have an IV placed, right? Because we want to have access. So when we start doing these tests, if things go awry and we need to admit that patient and do some emergency action on them, we have IV access. So they'll come in. Now this is in general. Not all facilities will place an IV and have the patient be ready for that IV access, but I have worked in several offices, well, several hospitals, sorry, where I've seen these tests being done, and most of them will be prepared just in case what the patient is experiencing is not that they're, newly diabetic, but it's something that's wrong, with their heart, or something that's wrong with their kidneys or liver or something. So just be aware that they may or may not have, placed the patient, an IV in the patient. But they go in to have this test done, this GTT test, and what they do, the test typically takes anywhere between 3 to 5 hours, and the patient will drink. If they have no problem drinking, then that's definitely the preferred route. Remember, we go from least invasive to most invasive. Now, if they have dysphagia or they have an inability to swallow, then we will place an IV, and we can give an IV dose of the glucose that we're going to be administering to the patient. But again, we prefer that they just swallow it. So they go in. They don't have an impaired swallowing mechanism, so they go in. They haven't had a previous CVA, so there's no problem there. And they come back. We ask them to drink this 6 ounces of severely high glucose content drink, and then we have them go sit in the waiting room, and then a half an hour after that, we'll draw multiple lab draws. And we'll do this multiple times throughout the 3 to 5 hours. And what we're doing is we're taking that information and seeing exactly what the body does with that excess glucose, right? Is the body able to, are the alpha and beta receptors able to successfully respond to that excess glucose? Or do we have an impaired ability to control that extra sugar in the body? If there is that inability to control that excess sugar, then the patient will be diagnosed with diabetes mellitus type 2. Excuse me. 2 other tests that we have. The patient will be monitoring their own glucose levels, and we as nurses will be monitoring glucose levels while they're in the hospital. And this is just the basic monitoring test that we do once a patient's diagnosed with diabetes. And we want the patient's glucose levels to be 70 to 110 if they're fasting, and then 100 to about 145 if they're eating food, right? Remember, at 150 and over, the patient will be spilling sugar over into their urine, which is an indicator that their kidneys are not able to handle all of the glucose that's in there, right? That's a very bad sign. That's a sign that the kidneys are being injured, okay? So we want to make sure that the blood sugar level's below 150 when it's just day to day. The third test is the glycosylated hemoglobin test. That's the HbA1c, or just A1c. And this monitors a diabetic's management of their glucose over the past 90 days or 3 months, right? If you're diabetic, we want this test result to be less than 7. Anything over 7 is considered very poor management of their diabetes within the last 90 days. And then, again, we talked in class, you don't need to fast for glycosylated hemoglobin. It is looking at a 90-day period, so that patient can have breakfast or whatever before they go in for their HbA1c lab draw, right? Okay. Now we're going to take a look at some of the medications that we use for patients who are diabetic. First, we're going to, remember, we like to go from least invasive to most invasive. So if you have type 2 diabetes, we're going to start the patient on an oral anti-diabetic agent. The one for block 2 that I would like you to know would be metformin. Now, remember that this is used for type 2 diabetes, metformin, right? And the initial thought behind a patient who's newly diagnosed for diabetes is that we'll try to get them to manage their diabetes with diet and exercise alone. That's step one. The reality is, though, that doesn't work for most patients. Will we see patients who are successful in that? Absolutely. But it's not something that is typical. So we're going to have to give them some help with that. And the way we do that is we add oral medications to help with that, okay? So metformin, metformin, metformin is a medication, an anti-diabetic medication that treats type 2 diabetes. And we know that it's what it does specifically in the body is it lowers the amount of sugar in the blood, and it does this by lowering the amount of sugar that is produced in the liver. The second thing that metformin does that's really neat is it increases the sensitivity of the cells, of the insulin cells. Well, specifically what it does is it increases the sensitivity of muscle cells to insulin. So the insulin, our muscle cells recognize the insulin easier is what's happening in the body. So its major contribution, metformin, again, is lowering the amount of sugar produced by the liver, but it has a side component where our muscle cells would recognize the insulin in our body. So it makes our muscle cells more sensitive to recognize the insulin in our body so that we can utilize it better, right? Another medication that might be added, let's say that the metformin is not working by itself alone. So it's working okay, but it's not working to 100% of where we want our patient to be. The physician may add glibenclamide to have an extra medication on board that will help with managing the patient's diabetes. Glibenclamide is Glibenclamide, glibenclamide. And glibenclamide is a wonderful medication that works in the body in conjunction with the metformin. The glibenclamide helps your body produce less glucose from your liver. It does not cause the body to make more insulin. So it just literally helps our body produce less glucose from the liver. So with glibenclamide, we see less hypoglycemic events, right? Like we do with metformin, because metformin has that component where it also helps with the insulin. So with the muscles and the insulin recognizing it. So glibenclamide has been found to lower blood fat levels as well, which is interesting. When they did their evidence-based, a couple evidence-based articles said that as a side benefit, glibenclamide helped lower fat levels, which contributed to the patients losing weight as well. So trust me, that group you have to read that article if you get a chance. It's really interesting, the study that was done in the beginning when glibenclamide was trying to get approved by the FDA. So okay, so again, metformin can risk is hypoglycemia, not so much with glibenclamide, just because of how they work in the body differently, right? Okay, sorry. Here's the picture of the medications names. That way I wouldn't have had to spell them for you. So here's a picture of the medications names. And then, of course, I want you to bring forth that information that you learned in Block 1 about the insulin, their onset, peak, and duration. Be aware of when you would use each of these insulins And that's covered there on the right hand side. And then also when they would spike, so that you can be when to know to watch your patient closely for hypoglycemia. So education to the patient before discharge on what they're going to need to do once they get home. They're going to have daily routines that they're going to need to do, right? They're going to need to be monitoring their glucose frequently, at least 3 times a day, preferably 6 to 7, because we want them monitoring them for sure before every meal, right? And we want them to measure it in between meals, so that we know if the body's sustaining the glucose levels, or are we having like hypoglycemic events or hyperglycemic events based on the fact that maybe we don't have the medication dialed in just right. So again, they're going to monitor their glucose levels and keep a good record for their next physician appointment. They're also going to monitor and keep a good record of how many insulin, the amount of units of insulin that they had to administer, the type of insulin they're administering, when they're taking their metformin. We want them to repeat back all of the information we give them. When do you take your metformin? Do you take it once or twice a day, right? And of course, this is all determined by the physician. We start with once a day with metformin, but down the road, if the patient needs an increased dose, they may either say, 500 milligrams twice a day, or they may say 1,000 milligrams in the morning. It depends on the physician. So, but we want to make sure that the patient understands when they're supposed to take their oral anti-diabetic medications. We want to make sure they understand what the signs and symptoms of hypo and hyperglycemia are. We want to make sure that they're planning their meals ahead of time, and that they're coming up with some type of exercise activity that is appropriate for where they're at in that spectrum. They need to understand that in moving forward, now that they have diabetes, they can no longer take care of their own foot care, right? They need to now start going to a podiatrist. You can no longer go to the places that do pedicures, and the patients should no longer, clip their own toenails, just because there's a huge risk if there's even the smallest amount of injury to the toe. It could be, an ingrown toenail that could actually lead to them having to have their foot cut off, right? Because wounds do not heal in diabetic patients due to the amount of glucose that exists typically in their body, right? They just don't heal. So it's so imperative that if they get any type of injuries to their skin, they go and see their physicians right away. We want to make sure that they stay in touch with the doctor managing their care for their diabetes. Sometimes that can be your primary care physician, right? Sometimes it can be. So whoever's managing their care for their diabetes, they need to have continuous follow-ups with that doctor at least every 90 days in the beginning, so that we can make sure that the medications are, again, the right dosages, and that they're keeping good track of their, it's hard to get patients to write down their foods that they're eating, to keep a food diary. It's also very difficult to have them keep track of just how many units of each type of insulin that they're taking. But it's important that they do this, because if it's off, we need to see what the correlation is. If it's too low, is it because they're eating foods they're not supposed to be eating, or foods that they didn't plan on eating, or is it because that they're taking too much insulin, right? All of this, it has a huge impact on it. There's so many factors, and it will help the doctor drill down to exactly which of those factors needs to be adjusted. And they will always carry access to quick glucose tabs, sugar packets, honey packets, something on the person at all times, so that if they have an hypoglycemic episode, with each hypoglycemic episode, they will become more and more aware of what those initial signs and symptoms are, and then they can respond accordingly. Or if someone comes across them and they're unconscious, like I mentioned in class, then we can respond by treating them accordingly, right? So the reason that we push patients to exercise and lose weight is because the overall health of losing weight and exercising is it helps lower the patient's blood sugar levels and also helps with how the body responds to glucose and helps managing, makes the insulin receptors more susceptible. So exercise helps lower blood sugar, aids in weight loss, it eases stress. It's one of the best stress relievers that we have available to us, and just an overall feeling of well-being. Once you've exercised, you feel great. Once you've taxied your heart a little bit and it's you've worked out a little bit, you feel much better. So, and we know overall that it lowers your cardiovascular risk. So that's why we encourage patients to exercise. That being said, we want to make sure that they know the precautions and plan for when they're going to exercise, right? Because the exercise component itself, so when a patient is exercising, that episode will elevate the blood sugar levels, and therefore insulin must be adjusted for that episode of exercising. Insulin normally decreases with exercise. So when a patient's going to work out, we want to make sure they take and eat at least 15 grams of a simple carb snack right before their moderate exercise. And this is to prevent a hypoglycemic event, right? And then we know that once we're done exercising, the what's happening within the body carries on for at least an hour or two. So we're going to also make sure they're aware of that so that they're watching that post potential hypoglycemic event after exercising, right? So they're going to monitor real closely their blood glucose levels and then act accordingly based on whatever number they're getting when they monitor those glucose levels. And then again, when we get older, that variability happens more frequently with the elderly. So we're just going to educate them on that as well. Okay, so on a day-to-day basis, when a patient's healthy, we want them to keep their blood glucose level less than 150, right? Again, because we're spilling over into our urine, and that means our kidneys are not, they're being damaged and they're having to work too hard. The only exception to that is when a patient becomes sick, because they're going to need that excess glucose to deal with all of the variations of variability that's happening when a person's sick, right? They're under stress. They're going to be having their body's going to need a rest. It's trying to heal. All of this requires more more glucose on board to cover that need. So, sick day rules are different, and you need to know the sick day rules so that you are able to educate your patient on what they need to do when they're ill, right? Number one, they need to stay real close in touch with the physician that's monitoring their diabetic care. If the patient lives alone, then they need to have a neighbor check on them, or they need to have a family member check on them, because it's not safe when they live alone, because the risk of having a hyper or hypoglycemic event is so much higher when they're sick, right? Most patients think when they're sick that they should not take insulin because they're not eating, right? In their mind, that makes sense, but that's not true. We want to make sure patients who are ill never omit the insulin that they're taking, right? Or the diabetic meds. If they're on metformin or glibenclamide, they're not going to omit those medications. They're still going to be taking them, right? Even if they can't eat. What we are going to tell them is they're going to test their blood sugar more frequently, most likely every 2 hours. Q2 hours, they're going to be testing it and following up with their physician or the physician's assistant to find out what they need to do from there, right? And that will depend on whether or not the patient is nauseous and vomiting, right? If that's the type of illness they're having, or is it that they're having diarrhea, but they're able to keep food down? That will definitely alter how much insulin is needed, right? So there's a lot of variables in this. One thing we do know that no matter what their sick problem is, whether it's respiratory or whether it's GI, they are definitely going to have to rest. This is not a time you want to work out. We are not going to work out ever when you're ill. This is true for everybody. It puts it puts everybody at a higher risk of a virus traveling through the body and attaching to one of the organs in the body. That's a true reality. Evidence-based practice has shown that that is a risk. It's a much higher risk. So we do not want patients working out when they are sick. It's not safe either. Having a patient work out when they could have a hypoglycemic event, right, and pass out. So we want to make sure they're aware that they should not work out, but they need to rest and give their body time to heal. We want to make sure that they are also drinking plenty of fluids to prevent from becoming dehydrated, right? Again, preferably water and things that aren't going to cause them, not to mess with their blood sugar levels, as well as hidden diuretics. A lot of patients don't know that tea can cause you, it's a diuretic. It causes you to urinate. Coffee, same thing. So we want to push fluids, but quality fluids like water. And we want them to take their blood glucose levels again every 2 hours. And if they get a reading that's below 150, when they're sick, then we're going to encourage them to eat some carbs, right? So that we can raise that blood glucose above 150. So they have those reserves on board to deal with what's happening with the elevated insulin levels in the body. So in general, if they suspect they have an infection, they need to contact their doctor to follow up with direction on what they need to do. They also need to, if their infection or what's going on with the GI issue or the respiratory issue lasts more than 2 days, they need guidance from their MD as well as where they go from here, right? If they have vomiting or diarrhea that lasts for more than 8 hours, they're definitely going to be in touch with their doctor and getting in to get additional medications to help with the side effect of those two things, right? If they test their blood sugar generally and it's over 400 if it's over 400 2 times in a row, then they're going to get on the phone with their physician and say, look, my diabetes is typically managed, but now I've had 400 readings. So I'm thinking I might be getting a virus or I might be getting a bacterial infection, right? So they can head off an infection that's headed that way, right? And which means that we can treat it sooner. Does it mean that we can head it off and prevent it from occurring? Not usually, but at least we can stay on top of it and start to treat it sooner. They are going to be testing their urine frequently, and they're going to be looking for large amounts of ketones or sugars. And so if they start, while testing their urine daily, if they notice there's a large amount of sugar or they have large amount of ketones, then that's again another indicator to get in touch with their medical doctor, because they might be able to get a jump start on something going on within the body. And then if they wake up and they're having more extreme fatigue than usual, if they're ever short of breath or dizzy, they need to get in touch with their MD right away so they can have the doctor tell them go 911 to the hospital or whatever the physician wants to do to help treat them. In general, we encourage diabetic patients or patients who are immunocompromised to begin with to get flu shots every year. It's recommended because this will give them added protection so that they don't get sick from the most common flu for that year. It needs to be done yearly. We know that the virus that happens changes from year to year, right? The most prevalent virus. Pneumonia vaccines are typically given at a maximum of 2 injections per life. Tetanus shots are also kept up. We encourage them to keep them up, and you get a tetanus shot once every 10 years, unless there's been some type of injury and the physician may warrant giving you an additional tetanus shot. If there's like, a rusty can where a patient was to get an injury from a rusty can, they may give an additional tetanus shot just to avoid having potential major complications from that. We're also going to educate them to tell people who are sick to stay away, especially young children. Remember, young children are developing their immune system, so they're going to be carriers of all kinds of wonderful things that we don't want to catch. So we're going to encourage them to stay away. So, and then the patient, we're going to encourage the patient to stay away from areas like grocery stores, swap meets, places where there's large amounts of people that could be ill and that could be potentially causing them, to become ill as well. We're going to encourage the patient to wash their own hands very often so that they can, if they touch a countertop that happens to have, some kind of infection there, and then they touch their eye or their mouth or whatever, and there's that port of entry. So if they're washing their hands frequently, they can prevent, spread of illness that way. When we look at what our concerns are with patients who are diabetic, we're looking for preventing lifelong damage to their organs from head to toe. So we're looking at their eyes and retinopathy. We're looking at sensory changes. We're looking at nephropathy, right? We're looking at vascular disease, autonomic neuropathy, affecting sexual dysfunction, whether this is erectile dysfunction due to the damaging of the tiny nerves, or causing impotence in general, or having an impact on the libido of a patient, right? So we're going to educate them on all of the non-visual problems that could be happening in the body. One of the reasons many patients have said to me that they don't comply with the medications is because of that they can't see the damage that's occurring. So they don't believe that there is any problem with having this excess glucose in their body. So it takes a lot of education to help them understand what's going on in the body when they have diabetes mellitus. Okay, it's important because they will cause permanent damage to these organs if they don't get their blood glucose levels lined out, right? Macrovascular issues like atherosclerosis changes, where they have that plaque buildup, can lead to coronary artery disease, cerebrovascular disease, as well as PVD or peripheral vascular disease. We need to make sure they're aware of that. The microvascular aspect is looking at the smaller veins and the smaller vessels that would be, of course, impacted first, as we discussed in class. So we're looking at retinopathy and nephropathy. And then we're looking at the neuropathic changes like the peripheral neuropathy, autonomic neuropathies, or neuropathies, hypoglycemic unawareness, neuropathy, and then, of course, sexual dysfunction. All of these are risks that patients take when their diabetes are not managed. And this is just a picture of a neuropathic ulcer that a patient had who wasn't even aware that he had it on his foot due to the lack of sensation that occurs over time with having that excess glucose in the body. And so just to wrap up this section, we need to educate our patients that anywhere from steroids, other medications that they may be taking can impact the blood sugar levels in our body, right? For example, steroids increase blood sugar in our body. Stress increases blood sugar levels in our body. Alcohol increases blood sugar levels in our body, whereas aspirin and antibiotics, they decrease the glucose levels in our body. again, exercise decreases it, steroids increases it, decongestants increase it, right? So there's a lot of factors that go into that we're implementing outside of our regular medications, our regular diabetic medications, that can impact the amount of blood glucose that's in our body, right? So we need to take all of these into account. Again, I'm just going to repeat it. Things that increase the blood sugar in our body, obviously when we're eating, that increases the glucose in our body, right? And thus the insulin that we need to cover it. Steroids, stress, alcohol, decongestants, all increase it. And then things that decrease it, that we wouldn't think that decrease it, but we need to educate our patients, would include antibiotics and aspirin, right? And exercise. So again, this is just a wrap up of the first section, and then we're going to move on to the next section of our endocrine system. Now we're going to take a look at the thyroid and parathyroid glands within the endocrine system. They play a vital role in cellular interactions, metabolism, growth, reproduction, aging, and then of course responding to adverse conditions that are entering our body and occurring within our body, right? So that's one of the things, is our body's immune system responding to what's happening in the body, right? And we're going to look at the negative feedback mechanism. The negative feedback is when something that occurs when some function of the output of a system, process, or mechanism is fed back in a manner to reduce the fluctuations in the output, right? So it'll overall cause a change in the input and thus affect the output. That's what the negative feedback mechanism, that's just a reminder from A&P. And then we're specifically going to look at hormones. We have hundreds of hormones that different organs throughout our body use and send out to regulate different aspects of our body. For example, amino acids and amines, peptide proteins, steroids, fatty acids. There's a really good table in your book, your Lippincott book 52-1, that talks about hormones and their interaction and job within the body itself. Now you'll notice that hormones are secreted from head to toe by different organs. Again, we have our hypothalamus, our pineal gland, pituitary gland, thyroid gland, hypothyroid glands, thymus gland, adrenals, our islets of Langerhans, which of course are in our pancreas, and then of course our sexual organs like our ovaries and our testes. All of these react with hormones they secrete hormones to respond to the environment and to keep our patients safe and healthy, right? Again, here's another picture of the pituitary gland and the hormones that are secreted through the pituitary gland. So we had the kidneys, and ADH and vasopressin, and we have uterus and breast with oxytocin, and then you can just look through the others. The big ones that we're going to discuss today is the thyroid gland, and specifically the TSH, or this thyroid stimulating hormone, right? And calcitonin, and finally, where's the other one? The parathyroid glands, right? Spitting out the parathyroid hormone. Okay, so we're going to take a look at all of these hormones and how they have an interaction in our body and their job within the body, right? So we have, again, our thyroid gland. Our thyroid gland is responsible for the T3 hormone, T4 hormone, and the calcitonin hormone. Again, iodine is contained within the thyroid hormone, right? And so the TSH is from the anterior pituitary, and it controls the release of the thyroid hormone, which all controls the metabolic activity within the body, right? And so we have an understanding that T3 is more potent and rapid acting than T4, but they both act together to help regulate metabolism within the body. And you might also, when you're doing your research in Lippincott and taking NCLEX questions, it may be referred to as T7 instead of T3 and T4, which are broken out. And then the other part of the thyroid hormones is not just T3 and T4, but calcitonin. Now, calcitonin is a hormone that is used to respond to high levels of calcium and react accordingly, and then we're going to discuss that in detail here shortly. So here's a picture of our thyroid gland. You'll notice that it is in the throat, and excuse me, excuse me, it is located on the trachea, just below the hyoid bone, and the thyroid cartilage. So when you go to your doctor's office for your annual checkup, he or she will stand behind you, put their fingers lightly on your throat, and tell you to swallow. What they're feeling is to ensure that you don't have any nodules on your thyroid gland, right? So when we do a thyroid check, we should feel nothing if we have a healthy thyroid. When there is something felt, they're feeling those nodules that are on the gland, and then there needs to be additional follow up to find out whether or not those nodules are benign or whether they are malignant and can cause, cancer. So here's another picture on the left-hand side. We know that the parathyroid glands, there's 4 of them, they lie directly on the thyroid gland. So you can see that in the left-hand side. Breaking down the parathyroid and thyroid controls our metabolism, and our thyroid responds to the pituitary gland's secretion of TSH. TSH comes from the pituitary gland. The thyroid stimulating hormone, or TSH, is what tells the thyroid gland to produce T3 and T4 when necessary. The thyroid gland also is responsible for producing calcitonin, which is another hormone, and calcitonin is its job is to directly decrease the blood calcium concentrations when the blood calcium is too high. And then we have the parathyroid hormone, which will secrete PTH, or the parathyroid hormone. And its job is to increase the calcium levels when our calcium levels in our blood are low. We already talked about how you assess the thyroid gland, right? Physician stands behind us and should feel nothing if the thyroid gland is healthy. So let's first take a look at our thyroid gland, the T3 and T4 in our serum. So if we have an elevated T3 and T4, that means we're hyperthyroid. This can be due to a tumor on our thyroid. It can be due to the fact that a physician went in and was doing some thyroid surgery, and they were manipulating the thyroid gland, releasing tons and tons of T3 and T4 into our blood, right? It can also be due to our pituitary gland malfunctioning, right? Because we know that's where we get the signal that's where that TSH is released, right? So it can be a combination of what's the cause of having too much T3 and T4. Is it a pituitary gland problem? Is it that we were having thyroid surgery and the gland was being knocked around, releasing too much T3 and T4? Or is it that our thyroid replacement medication is too aggressive and too high, right? There can be a lot of reasons that the elevated serum of T3 and T4, right? However, when the thyroid is the cause of having too much T3 and T4, you will see a direct correlation between that and the TSH levels. They have what's called an inverse relationship. In other words, if T3 and T4 are high due to your thyroid, then you're going to see the TSH levels be low. They're going to be low. And the reason that is because if the elevation of T3 and T4 is due to the thyroid, once the body recognizes we have too much T3 and T4 in the body, it's going to send a signal up saying stop making T3 and T4, right? So it's going to tell TSH stop. So TSH is going to be low, T3 and T4 are going to be high, and then vice versa. So if we have on the right hand side there, if we have hypothyroid, meaning the T3 and T4 levels in our blood are low, then that's going to send a signal up saying we need the TSH to produce more. So we're going to have TSH levels go high, right? And those low levels will start to level out, okay? So that's when it is due to a thyroid cause. When we look at the decreased T3 and T4, it may not just be a thyroid issue. It could be a pituitary gland issue. Because remember, the pituitary gland is what's responsible for secreting TSH. So the pituitary gland is responsible for secreting the thyroid stimulating hormone, right? We can't produce T3 and T4 without the pituitary gland telling the TSH hormone to do that, to create the T3 and T4 and release it out, right? So that would make sense. Now let's look at a patient who is hypothyroid, right? Unlike hyperglycemia and hypoglycemia, right? So let's just refer back to what we just learned with glucose and in our body. When you have too low of sugar, that is a very severe situation and can be life-threatening. Whereas too high, we can maintain that much longer before it becomes a life-threatening situation. Well, it is the exact opposite with our thyroid gland. Too low of a thyroid gland, we can manage that much, much longer without having any major complications. Whereas too high of a thyroid gland that's functioning too fast and too high in the body can be very life-threatening. So first, let's take a look at hypothyroidism. Hypothyroidism means there's a hyposecretion of the thyroid hormone, which decreases the amount of T3 and T4 in the body. So you know right offhand, if you have a decreased T3 and T4, then the TSH must be high, right? Because they have an inverse relationship. Your patient's going to present when you start thinking in your mind, well, what is my patient going to look like? They're going to be gaining weight by eating even the smallest amount of food, right? So they have easy weight gain. That's because their metabolism is extremely slow. They're going to have very dry, brittle hair on their head. And on their body, you're going to see a loss of body hair. They're going to be very intolerant to cold weather. And so they're the ones who are always cold, usually in a room where other people are either comfortable or they're even a little bit warm. And as far as the heart is concerned, cardiac concerns, the patient's going to be Brady. How do we fix a patient who's hypothyroid? Well, we're going to give them a replacement thyroid medication, right? Like the one I want you to know for block 2 is levothyroxine. So we're going to order levothyroxine. Levothyroxine will cause the body to create more T3 and T4. Okay, so it's a synthetic form of stimulating thyroid to make the body create more T3 and T4. When a patient goes on a artificial medication that stimulates this mechanism and this action in the body, the physician does so slowly because the physician's very careful not to cause a patient to switch over and become hyperthyroid. So again, they start slow and go low, and therefore it can take a year to 2 years for a patient to really get their thyroid medication where it needs to be. We're going to monitor our patients when we're giving any type of thyroid medication for hyperthyroid. So it's important that even though your patient's hypothyroid, that they understand the signs and symptoms of hyperthyroid, so that if the medication sends them into that realm, they can intervene, get in touch with their physician, so that we know that it's going to be managed really quick, and there's not going to be even more problems with the patient. And of course, we're going to be monitoring their cardiac status rather closely during this time. All right, moving on. So here's a picture of what we just talked about, the hypothyroidism, hair loss. They're going to be very apathetic, very lethargic, tired all the time. They're going to have very coarse, scaly, dry skin, muscle aches and weaknesses. Remember, everything is slowing down from the body, so they're definitely going to be constipated. Menstrual disturbances, right? They may miss cycles, or they may have long cycles. Intolerance to cold weather, receding hairline, eyelid edema. They may have a dull blank stare, a thick tongue, speech, anorexia, brittle hair and nails. Late signs would include decreased level of consciousness, thick skin, cardiac complications, weight gain, bradycardia, and subnormal temp if you take the patient's temperature. Now flipping over to the hyperthyroid, which of course again is worse than hypothyroid, remember. We're going to look at hyperthyroid, which is a hypersecretion of the thyroid hormone, which will increase the T3 and T4. So when T3 and T4 are increased, it sends a message that there's enough of TSH, that it doesn't need to release anymore. So again, if T3 and T4 are elevated, TSH will be decreased. These patients are already hyper, so they do not need additional stimulants. So they're going to avoid anything that has caffeine or stimulation in it. Coffee, teas, any kind of pop, Coke that has caffeine in it, any kind of illegal drugs, or even drugs like Adderall that's a stimulant with it. We're going to actually order these patients to take sedatives to calm them down. We're going to place them in a very cool, calm environment. So we're going to have their rooms be really cool. We're going to turn the lights off and have it be calm. We're going to cluster care so that we're not going in every 10-15 minutes to ask to do something with them. Every time we go in, this elevates their anxiety and causes a hyperthyroid patient to be more at risk for going into a thyroid storm. They're going to be on a cardiac monitor so we can monitor those arrhythmias that are happening and making sure that they don't get into a dangerous arrhythmia. We're going to either prepare them to take radioactive iodine as a medication to try to kill off part of their thyroid, to try to get them within a normal range, or if they've already had radioactive iodine therapy, they may now be in your care to prepare for thyroidectomy surgery. We're going to be watching for a thyroid storm, which we're going to talk about the signs and symptoms of that. Now try to visualize what your patient's going to look like. They're going to be patients who lose weight without even trying. They're going to be extremely irritable and moody. They may or may not have an enlarged thyroid or a goiter. They do tend to have protruding eyeballs, or their eyes look very large and sunken. You're definitely going to see some hypertension and cardiac palpitations, and their skin will be very smooth and their hair will be smooth as well. Here's a good picture of a patient who is hyperthyroid. Again, they have intolerance to heat, so they're fan is going to be blowing on them, and it's never going to be enough. Because remember, this intolerance to heat's coming from internally with their thyroid overworking. They're going to have fine straight hair, bulging eyes, facial flushing, enlarged thyroid. They're going to be tachycardic. Their blood pressure is going to be elevated. Specifically, their systolic will be elevated. They may or may not have breast enlargement. This includes males. They're going to be losing weight without even trying. They are going to include, this will include muscle wasting. They may have a problem with edema, localized edema. Their system is working double time. So typically with women, we see no menstrual cycles or amenorrhea. They're going to be working overtime. So unlike a hypothyroid patient who's got constipation, with a hyperthyroid patient, you're going to have diarrhea and lots of bowel movements with diarrhea. They're going to be tremors, and they could have finger clubbing. Graves' disease is the #1 cause for hyperthyroidism. When you get to block 3, you're going to learn a lot more about Graves' disease. But just make the connection that if a patient has Graves' disease, that the most common cause of that is hyperthyroid. Thyrotoxicosis is excessive output of the thyroid hormone. This can lead to a thyroid storm. An autoimmune disorder can be the cause of a patient having a hyperthyroid. Hyperthyroid affects women approximately 8 times more than men. Again, picture your patient. They're going to be nervous, agitated, irritable. They're not going to be, their cooperation is going to be limited to very short amounts of period where you'll be able to get their attention. They're going to have a rapid heart, rapid pulse, heat intolerance. You will literally visually be able to see the tremors in their hands. They may be jiggling their leg really quickly due to the nervousness. Skin flushing, warmth, soft and moist. Exophthalmos, increased appetite, weight loss. So even though they're eating more, they're going to have weight loss, potentially muscle loss. Elevated or a systolic BP, and then cardiac dysrhythmias. So how do we treat hyperthyroidism? Again, radioactive iodine therapy. Remember, we want to keep these patients when they're on RAI. We're going to educate them at home. They're going to use a private toilet if possible. If not, they're going to flush the toilet twice. We're going to ask them to bathe daily and to wash their hands frequently. We're going to ask them to use disposable eating utensils. We're going to ask them to sleep alone and avoid intimate contact for up to 4 days after using radioactive iodine therapy. What else? We're going to change their linens on their bed frequently. They're going to have their own towels to use, right? Their own bath towels to use. And then clean those after they use them. They're going to keep their clothes separate in the hamper, dirty clothes. They're going to keep them separate. If a woman has this if a woman has hyperthyroidism and is getting RAI treatment, then there will be absolutely no breastfeeding during that time. We're going to also encourage that they not get pregnant during this time for up to 6 to 12 months after using radioactive iodine, because there have been some studies to show that there is a risk for malformations with the embryo. The pill is absorbed within 3 days and can take up to 3 months or 3 to 6 months for the effect of what's in those radioactive iodine pills to stop working in the body. So that's why we're saying we're going to take all these precautions for up to 6 to 12 months after the patient has been on radioactive iodine therapy. So then moving on to the medications there, propyl, thiuracil, and methomazole. They're oral medications that are used to manage hypothyroid or hyperthyroid. They're anti-thyroid drugs that have a mechanism of action that they work by stopping the thyroid gland from making too much thyroid hormone. They're really great medications. So make sure you know those two medications. Not so much for this upcoming exam, but for the final. And then, of course, sodium or potassium iodine solutions. Those two make sense. And then looking at dexamethasone. So when we have large doses of dexamethasone, they inhibit hormone production and decrease peripheral conversion from T3 and T4. So those are really, dexamethasone is really a great medication to help with hyperthyroidism. And then beta blockers, while these medications don't change the amount of thyroid hormone in your body like the medications above, beta blockers do help with the symptoms. So they help make patients feel better, with the side effects of hyperthyroidism. And then, of course, if the radioactive iodine therapy doesn't work and the medications do not work, then the other option is to do either a sub or a total thyroidectomy, where we go in and we actually remove the thyroid gland, and then put the patient, if the patient has their thyroid gland removed, then we'll put the patient on thyroid replacement for the remainder of their life, right? So speaking of a thyroidectomy, if a patient does have thyroid cancer, of course, this is the treatment of choice for thyroid cancer. And it will be the treatment choice if nothing else works with reducing the hyperthyroidism as well. So we'll go in, physician will go in and do a modified or radial neck dissection. Before surgery, the goal is to reduce the amount of stress the patient is having and anxiety in relation to the surgery, and then of course post-op worrying about the thyroid storm happening. Anytime we mess with the thyroid gland, we're knocking T3 and T4 into our blood, and we are putting the patient at a risk of a thyroid storm. We're going to educate the patient that preoperatively that post-op there's going to be dietary needs that are going to have to be followed, and that would include, so they're going to go from MPO to a liquid diet to a soft diet, and then of course we're going to educate them on what kind of diet moving forward they're going to need. Now remember, these hyperthyroid patients have been able to eat pretty much anything and still lose weight. So one of the educational goals of us as nurses is to let them know that once we remove that thyroid gland, then they're not going to have, then they're going to be at risk for the hypothyroid patients, right? Gaining weight really easy by eating normal amounts of food. So we're going to have to educate them on that. And then, of course, during their post-op period where there's a risk for that thyroid storm, we're going to completely avoid any caffeinated beverages, any stimulants, no energy drinks, no caffeine, no pop, all of that. And we're going to keep them in a cool, calm environment. And we're going to also educate them that post-op, they're going to need to keep their head and neck support gear on, and making sure that they keep their head in a neutral position. So again, thyroidectomy is the removal of the thyroid gland. And remember, the parathyroid glands, the 4 of them lie on top of the thyroid gland. So again, the physician will place those 4 parathyroid glands into the patient's arm or stomach, wherever they choose, and they will function just fine. Keep in mind, they're the size of a grain of rice, so many times one or more may be injured during surgery. So they'll implant as many of the ones that are viable into the patient's arm, and they will work anywhere when they're placed in the body. Once the thyroidectomy is completed for a hyperthyroid patient, they will now become hypothyroid, meaning they're going to need synthetic thyroid hormone for the remainder of their life. And so they're going to go they will now become what the hypothyroid patients do, which is being monitored every 90 days regarding their thyroid medication, making sure that that they're within a therapeutic range. Now, once physicians start a particular type of thyroid hormone replacement therapy like levothyroxine, they will stick with that brand. Just because it gets really tricky switching brands, it puts the patient at a risk of putting them in a hyperthyroid state. So because that's too dangerous, they're going to stick with that one brand that they initially went with and just manage the patient by adjusting the doses. So again, we're going to make sure that the patient understands the signs and symptoms of hyperthyroid because they're on a thyroid replacement. And even though they don't have a thyroid in their body, we can still cause hyperthyroid without a thyroid in the body by giving too much synthetic thyroid hormones in the body. So they're going to be aware of that as well. And know that we're going to go low and slow with that. So just tell the patient it's going to take a good year, maybe even longer, to get their levels lined out. So the top 3 post-operative thyroidectomy concerns. Of course, airway is number 1. We've been in that area causing, cutting and removing a gland, and it's going to cause the body's natural immune response, which is swelling, to try to, that's part of the immune response, is to swell and try to fix the problem that's occurred. So swelling over the airway is a very, very likely thing. We just don't want swelling to occur to the point where the patient loses their airway. So right by the bedside, we're going to have an emergency trach kit, and we're going to have so a tracheostomy insertion set is going to be right by the bedside, and we're going to visually be watching these patients extremely closely post-op. They are going to be your priority patient in any kind of patient situation. Secondary concern would be a thyroid storm. Remember, removing the thyroid gland, we're knocking those T3 and T4 throughout the body, so that the body's going to have an abundance amount in the bloodstream. So this is going to put the patient at risk for a thyroid storm. There is no cure for the thyroid storm. We can only treat the patient for the thyroid storm. The biggest thing with thyroid storm is we have to cool the patient down, because in a thyroid storm, the patient is raging. They're burning up, and we will do everything, including putting a packing the patient full of ice. We will cool the inside of the patient down by giving them IV fluids. That's probably one of the best ways to react to a thyroid storm. We're going to put a cooling blanket on them, whatever we have to do to get their temperature down and save the brain tissue, right? And then finally, tetany, low blood calcium, right, is obviously a concern for thyroidectomy concerns, right? Because we moved the parathyroid glands and probably injured one, if not maybe even 2, during the removal of the thyroid gland and replacing the parathyroid glands in the arm. So we're going to make sure that the patient is not negatively impacted as far as their calcium levels are concerned. So we're going to be on the lookout for hypocalcemia, and we're going to treat them accordingly. So again, thyroidectomy is the treatment choice for thyroid cancer as well as hyperthyroid when the other RAI and other medications have not worked. This looks like, this looks like the same slide. Of course, they're going to be anxious and stressful. That's one of our jobs, is to calm the patient down, right? As well as, have the family member help us with that aspect of it. Yeah, we talked about that. Okay, parathyroid glands. Again, there's 4 of them located on top of the thyroid gland itself. They regulate the amount of calcium and phosphorus balance within the body. And we know that increase in parathyroid hormones elevates the amount of blood calcium, and And it also increases it by the amount of calcium that's absorbed from the kidney, intestines, and bone. Parathyroid hormones and the phosphorus levels we're going to take a look at in detail. So moving on to the parathyroid gland, we know that the parathyroid gland secretes parathyroid hormone to increase concentrations of calcium in the blood. We want a perfect balance of calcium and phosphorus in the blood, right? To maintain a healthy heart and a healthy brain. And when we have a patient who has too high levels of calcium, we know that they can cause, stones that can be extremely painful as well as very traumatic to the kidneys at times when we're passing them. I've actually had a patient in the past that lost one of their kidneys because the calcium stone cut the kidney up really bad. So we got to be really careful. We also know that increased calcium levels, if too high, can cause mental disturbances as well as cardiac issues and complications. So it's not good for the heart, it's not good for the kidneys, and it's not good for your brain. Decreased calcium levels can lead to tetany or muscle spasms. And so we fix increased calcium levels by giving the patient calcium, right? So calcium gluconate, that's what we're going to give a patient who has too little calcium in the body. We're going to give them calcium gluconate. So the labs that we use to check and see what's going on with the parathyroid, is a serum parathyroid hormone lab as well as calcium levels, right? Because we know that the parathyroid hormone is directly in charge of the calcium levels. Chavoxine is that spasm facial muscle when the face is tapped over the facial nerve between the eye and the ear on the cheek. It'll have a response, as well as trisosine. That's that carpal pedal spasm when we inflate the blood pressure cuff above the patient's systolic blood pressure, and then we leave it in place for about 3 minutes. And then we'll get that carpal pedal spasm. So this is a great picture that shows if you have your thyroid, your thyroid's responsible for calcitonin, and your parathyroid is responsible for parathyroid hormone. If we have calcium levels that are too high, it tells the thyroid gland to release calcitonin, which will increase the calcium deposits in the bones. It'll also decrease the amount of calcium that we are ingesting from our food through our intestines. And it will decrease the amount of calcium that we reabsorb from the urine. So we'll just urinate it out. As a result of these 3 things, our calcium levels will fall. Okay, and then our body becomes homeostasis. But if the brain says the calcium levels are too low, then that stimulates the parathyroid to release the parathyroid hormone, which increases calcium release from the bones into the blood. It also increases the calcium uptake in the intestines, and it will increase the calcium reabsorption from the urine, which will all result in the calcium levels in the blood to rise. So when looking at hyperparathyroidism, this is the primary hyperparathyroidism occurs 2 to 4 times more often in women than men. And your patient may have absolutely no symptoms at all, or they may be experiencing signs and symptoms from several of our body systems. They may be very apathetic, very fatigued, muscle weakness, nausea, vomiting, constipation, hypertension. They will be hooked up to a cardiac monitor looking for the cardiac dysrhythmias that could occur. We treat hyperparathyroidism by surgically removal of the abnormal parathyroid tissue and giving the patient hydration therapy. We have to be on the lookout for hypercalcemic crisis. This can occur with extreme elevation of serum calcium levels. This can result in neurologic, cardiovascular, and kidney symptoms that can be literally life-threatening. We treat this by rapid rehydration with large volumes of IV isotonic saline fluids, as well as calcitonin and corticosteroids being administered in emergencies to reduce the amount of calcium in the blood, and by increasing the calcium deposit back in the bone. Hypoparathyroidism is caused by abnormal parathyroid development or the destruction of the parathyroid glands. For example, we have the surgical removal where they are injured, or the body's autoimmune response where it attacks itself, or if you have a vitamin D deficiency. Remember the correlation between vitamin C and vitamin D, right? Your patient will present with tetany, numbness, tingling in the extremities, stiffness of hands and feet, bronchospasms, laryngeal spasms, carpopedal spasms. They will definitely be anxious, irritable, depressed. They can have some EKG or ECG changes, and if bad enough, they can have delirium. Again, we're going to lean back on the tetany check, the Shavak sign check, and the Trousseau sign check that we discussed earlier today. Now, if a patient has too low of calcium, what we're going to do is we're going to give that calcium replacement, right? Because we know that low calcium can lead to serious complications pretty quick, as calcium plays a very important role in muscle and cardiac function. So we got to react real quick and get that calcium replaced with calcium gluconate pretty quickly, okay? We know that early signs of low calcium include head to toe, right? So body tingling, tetany, and patients can be prone to seizures. So we're going to initiate seizure precautions. We don't want to lose our airway, so we're going to make sure we have a trach insertion kit by the bedside. The patient's going to definitely be on O2, and we're going to have suction at the bedside too for an emergent need. So we want to realize that since surgically removing the thyroid is done more frequently than removing parathyroid, we know that the parathyroid glands are on the thyroid itself. They can get injured during this time, right? We discussed this in class. So we just need to be on the lookout that can occur and be ready for reacting if that does occur. Also, remember, if we have low calcium levels and they're just slightly low, there are ways that we can, remember, we want to always go from minimally invasive to more invasive. So we can literally encourage patients to take calcium supplements as calcium carbonate. There is, like Tums, Viactive or Citrasil, vitamin D for calcium absorption, dairy milk, dark green vegetables, and canned fish with bones. So how do we manage hypoparathyroidism? We need to increase the serum calcium level to 9 to 10 is within the normal range. We're going to administer calcium gluconate via IV. We may also administer phenobarbital to decrease the neuromuscular irritability, and then as well as a parathyroid hormone administration. There's a hormone called Natpara, Natpara, and this is a once daily injectable treatment of low calcium due to hypoparathyroidism. There is a high risk though for bone cancer when taking this, so this is often not advised or not often taken by patients. So, and there's also potential for a lot of allergic reactions. We want to provide a quiet environment, no bright lights, no sudden movements. and so forth. And then we're going to encourage a diet high in calcium and low in phosphorus. So this would include dairy products, green leafy vegetables, broccoli, orange juice, breakfast cereals, and then of course phosphorus. Remember avoiding soft drinks because they contain a lot of phosphorus, right? And some meats, hard cheeses, and whole grains will have phosphorus in it, so we want to be careful with that, right? Okay, the final two is thyroid cancer and goiter. Thyroid cancer is a rare form of cancer, and it will present as a fixed lump on the thyroid gland in the neck and or as an abnormal thyroid and calcium labs when they're drawn. Most physicians will advise their patients to completely remove the thyroid gland because we can live comfortably without our thyroid gland by getting thyroid replacement. So we will go back in and completely remove, the surgeon will remove the thyroid gland. And then of course you need to lean back on the knowledge that and the education that we just discussed with when a patient goes through a thyroidectomy, the concerns with that. Additionally, there may be additional radiation and chemotherapy as ordered. And then, of course, we just talked about the precautions with that as well. So bring that knowledge forward as well. We use the thyroid radiation directly to attack the tumor itself. And remember, the thyroid's located in the neck. So when we're applying radiation therapy in the neck, this is causing pain, swelling, and potential loss of airway. So we want to have, a trach kit by the bedside, emergency kit. And we want to also have really good skin care. We talked in class about that, avoiding the sun, not applying lotions to the area, not applying warmth or heat or cold, and just letting the area heal on its own. So chemo is done when the physician feels that maybe the cancer has spread outside of the originating site. And so we want to bring forth that knowledge about the chemo concerns with the side effects of having low platelets, low white blood cells, and low red blood cells, right? So patients having trouble clotting, having low immune system. So we want to keep, again, all of the sick individuals away, having the patient wash their hands thoroughly. So bring all of that knowledge forth that we discussed earlier today, right? And then goiters are mostly seen in underdeveloped countries due to lack of iodine. We treat that with potassium in foods high in iodine. Here in America, we usually don't have a problem because what we've done is we've added iodine to our salt, and we definitely don't have any issues here in America eating salt. So for the most part, so we don't see goiters here very frequently. However, hyperthyroidism can also cause a goiter to form. So when we do see it, that's usually the cause, is it's hyperthyroidism. And just be aware that this is, it's a physical appearance, right? There's really no medical necessity to remove the goiter, but we will do it for cosmetic reasons. Most insurances won't pay for that, so that's something the patient will have to cover on their own. All right, that will cover our endocrine system, and I hope you all are having a wonderful day. Thank you.